Malaysia, the government introduced the National Strategic Plan for Tuberculosis Control 2016 to 2020 to guide efforts in preventing, controlling and managing tuberculosis (TB). Its ultimate aim is to significantly reduce the TB burden in the nation and work towards a TB-free Malaysia by 2035. Tuberculosis is an infectious lung disease caused by bacteria. It spreads to the air when infected people cough, sneeze, or spit. According to the WHO, about a quarter of the world's population is infected with TB, but only 5 to 10% of them develop symptoms. TB can be deadly if untreated, so antibiotics are crucial for treatment. Symptoms include fever, weight loss, and chest pain. In 2050, there were nearly 10.4 million TB cases worldwide, resulting in 1.4 million deaths. The government strategy aimed to reduce deaths by 25% by 2020, limit reported cases to 100 per 100,000 people, and ensure universal access to diagnostic and treatment service, including a 90% success rate in treating multi-drug resistant TB. Now we move to problem 1, which is low TB case detection and cases of MDR-TB. In 2018, Malaysia had 93 TB cases per 100,000. In 2014, only 81 cases were detected, missing 6,000. Globally, MDR-TB cases are increased. As you guys can see the graph, Malaysia recorded its highest MDR-TB case in 2011, which is 141, and the lowest in 2004, which is 30. Next, the second problem is resources available not parallel with disease burden capacity. When there are many TB cases, the government and Ministry of Health face challenge due to limited resources, especially in higher burden states like Selangor and Kuala Lumpur. For instance, in Petaling, with 1.8 million residents, only 4 TB case managers are available, which is inadequate. This affects TB management effectiveness, as screening, treatment, and health education service require sufficient staff. Besides, the other problem is low case detection of TB among children. Government urgently need to address child tuberculosis as it reflects on transmission within our communities. Since 2030, the percentage of cases among children under 5 has steadily increased from 0.8% to 1.1%. The next problem is insufficient TB-HIV collaborative activities. In Malaysia, TB-HIV co-infection stood at 12.6% in 2010, with 690 case diagnosis from 2030 to 2070. However, joint HIV collaborative efforts has been slow, despite initiatives like policy modification and HIV testing for TB patients. Shockingly, as of 2008, only 11 of newly diagnosed TB patients received an HIV test, so urgent action is needed to improve collaborative strategy and ensure comprehensive care for those affected by TB-HIV co-infection. So, the next problem is inadequate policy for treatment of LTBI. The Ministry of Health in Malaysia lacks a specific policy for treating latent tuberculosis infection, LTBI, within its tuberculosis management guidelines. However, they recognize the importance of LTBI therapy for targeted population in TB control efforts. Guidelines emphasize considering TB development risk, transmission potential, and active TB likelihood. Adequate funding and improved reporting mechanisms are essential for effective LTBI management and overall TB control in Malaysia. Now we move to the point which is inadequate knowledge and awareness regarding benefits of BCG vaccination. By 2040, the TB and BCG vaccination coverage reached an impressive 97 to 99% provided free of charge. However, vaccine rejection is escalating, evidenced by a rise in parental refusal from 470 in 2030 to 1541 in 2015. Notably, 10% of urban Malaysia parents, particularly unemployed or first-time mothers, express reluctance. In addition, poor TB treatment outcome is one of the problem TB. Poor TB treatment was defined as treatment failure, loss to follow-up, or death. From 2030 to 2070, the Kuala Lumpur Federal Territory Health Department tracked TB-HIV patients. Of the 235 federally selected, 42.1% faced treatment failure, including death, treatment interruption, or so on. Poor adherence to TB treatment also heightened risk of drug-resistant relapse and mortality, with non-compliant patients facing twice the risk of death compared to compliant ones. So the other point is like of the adequate engagement of community in active TB case finding and treatment adherence. The Ministry of Health in Malaysia's National Strategy Plans highlights a gap in community involvement in identifying and treating TB cases. To bridge this, the proposal suggests enhancing community training and communication. This resonates with research from a low-income area with high TB rates, emphasizing the importance of people's understanding beliefs and habits along with their commitment to keep appointment in sustained participation in TB testing. Next, in Malaysia, inadequate TB support and legal measures contribute to challenge for TB patients. Despite free treatment, many discontinue early due to factors like HIV and distance from treatment centers. Overlooking psychological aspects complicates identified at-risk patients. TB stigma wasn't treatment dropout despite available defaulted transitors. To address these issues, the National Tuberculosis Control Program called for innovative approach. Next, the last problem is inadequate research and innovation in TB program. Tobacco use plays a significant role in tuberculosis TB, contributing to 20% of TB cases worldwide. Smoking not increase TB incidence but also impact treatment adherence and recovery. In Malaysia, 34% of TB patients were smokers in 2012 compared to 22.7% of the general population. To address this, early identification of TB patient is essential. Implementing an integrated TB tobacco cessation program in TB clinic and including international TB strategy plan can enhance the intervention effectiveness.
Thank you, presenter. So, move to the next slide, which is objective and strategy for tuberculosis. The first goal and strategy for tuberculosis is to improve TB case detection, which include developing national guideline and SOP, as well as improving TB screening and diagnosis, particularly for those at higher risk, in order to increase case notification rate from 79 per million people in 2050 to 100 per 100,000 by 2020. To accomplish this, WHO is implementing strong guideline and standard operating procedure such as Malaysia National Tuberculosis Control Program. They ensure consistency and efficiency across healthcare facilities while also having the ability to detect early cases and boost diagnostic capability. The second is to provide an effective tuberculosis screening program designed specifically for pediatric cases and contact. Our goal is to improve TB control among youngsters, drawing inspiration for successful efforts such as South Africa Pediatric Tuberculosis Program. Their method provides comprehensive screening, diagnosis, treatment, and service. WHO also integrates smoothly with HIV care and other child health initiatives to ensure comprehensive support with defined SOP and guidelines. They hope to shorten the process, making it easier to diagnose and treat pediatric tuberculosis cases successfully. The next step is to reduce the burden of tuberculosis and HIV in people who are at risk or affected by the both disease. The goal is straightforward, which is improve HIV screening among TB patients and test those living with HIV, TB, and latent infection. They give preventive treatment for both illness and guarantee that HIV and tuberculosis patients receive antiviral therapy. For example, a TB and HIV treatment program. This program bases screening, treatment start, adherence to patient-centered care recommendation, and confidentially. Move to the next, which is strengthen the programmatic management of drug-resistant tuberculosis. Develop comprehensive criteria for public health effort, diagnosis, treatment, and surveillance. The Communicable Disease Control Act of 1998 required them to establish standard operating procedure for dealing with patients who are lost to follow up. Regular training sessions guarantee that our medical personnel are prepared to manage TB cases effectively, both clinically and from a public health standpoint. The goal is simple: to improve drug resistance and TB management limitation and improve patient care results. The next step is to expand laboratory network and identify all TB cases. WHO will focus on increasing capacity for drug-resistant and TB diagnosis and ensure DST, particularly for resistant for high-risk patients. These include increasing LED microscopy for tuberculosis detection and establishing more TST equipment laboratories. Take the Global Laboratory Initiative as an example. Sponsored by WHO, it ensures that high-risk tuberculosis patients receive critical tests such as chain expert and culture-based DST, which increase lab capacity. Through this effort like GLI, country improve lab capacity leading to better TB diagnosis and treatment outcomes. So, the next step is to improve the management of latent tuberculosis infection. This includes the creation of standardized operating procedure and national norms, as well as the implementation of effective recording and reporting system. They hope to improve our LTBI program management by correctly recording patient and treatment outcome, as well as standardized care method. They like the National Program for LTBI Management in the United States. Are focused on systematic detection program for LTBI management and treatment across all healthcare facilities. This holistic approach can boost effort in tuberculosis prevention and LTBI care. So, the next is to expand the BCG vaccination program. The plan is to ensure all newborn get the vaccine regardless of their location or financial status. This will be done by the offering vaccination in the hospital or during postmortem checkup. By involving community leaders, politicians, and healthcare experts, they aim to make the BCG vaccine universal available, helping the global fight against tuberculosis and promoting public health. This effort is similar to the expanded program on immunization supported by the World Health Organization, which ensures Malaysian child get vital vaccination, including BCG. This collaboration not only increases vaccination rate but also support international TB control effort. So the next point is to ensure a steady supply of quality tuberculosis medication. Chemists play a crucial role, which is they advise patients on how to use their medication, including dose and possible side effects. This guidance helps patients take an effective role in their treatment and stick to their medication schedule. By working closely with chemists, TB patients receive better overall care, leading to improved treatment results and reduced spread of disease in communities. Next, they putting a plan into action that stresses teamwork among health organizations to better fight tuberculosis. By working together, they can make a bigger impact, avoid doing the same thing twice, and use resources better. For instance, the TB Reach program found new community-based ideas by teaming up with public health agency, non-profit, and international group. This way, they aim to improve how tuberculosis is handled, avoid doing the same work twice, and achieve better results. Next is to help families cope with the cost of tuberculosis. Support groups are formed to offer both practical and emotional help. This group also fight against discrimination and the stigma attached to TB, aiming to improve health results and treatment consistency, particularly for vulnerable individuals. The WHO Global Tuberculosis Program plays a vital role by aiding countries in creating policies that address issues like poverty and stigma. It ensures patients get complete care by integrating TB service into social protection program and support community organizations and support groups. Afterward, the TB control program is focused on improving research innovation. They creating a national TB research network and collaborating with local and international partners to advance research. This network will help develop evidence-based solutions aligned with the WHO and TB strategy. For instance, the World Health Organization Global TB Research Innovation and Development Initiative encourage collaborating among scientists, policymakers, and healthcare workers. It found research programs, support national TB research network, and help turn research funding into policies.
The first strength is the government has successfully achieved Objective 1 by partially addressing Policy Problem 1, which aims to improve TB case detection specifically among Malaysians. Before the NSP, only 81 cases per 100,000 were detected in 2014, leaving around 6,000 cases undetected annually. Through proactive measures and enhanced surveillance, reported cases surged to 25,391 in 2022, signaling a commendable increases in detection rates, as stated by the Health Minister in the Star News in 2024. Furthermore, the NSP has successfully addressed the burden of TB-HIV co-infection, a pivotal aspect of TB control. Collaborative efforts between the National HIV/AIDS Control Programme and the National TB Control Programme have been pivotal in reducing TB-HIV prevalence from 12.6% in 2010 to 5.9% in 2019, thereby solving the policy problem as evidenced by a steady decline in co-infection rates. Besides, between 2015 and 2017, the rate of active tuberculosis among newly enrolled PLHIV dropped from 9 to 4.7%, while TB-HIV patient prophylaxis coverage ranged from 70% to 79%. Moreover, the implementation of the PMDT has yielded promising results from Objective 4 in curbing the prevalence of multi-drug-resistant TB, addressing a policy problem 1. Through rigorous efforts, Malaysia has witnessed a significant reduction in MDR-TB cases, exemplified by a notable decline since the inception of PMDT. As the proof, data shows a peak in MDR-TB cases in 2011, but since of the introduction of PMDT, there has been a noticeable decline, particularly when comparing 2019 to 2015. So this decrease shows that PMDT is working well to stop the spread of MDR-TB. In addition, the strengthening of Malaysia's laboratory network has been a pivotal in bolstering TB diagnosis and treatment, partially solving policy problem 2. So, with the introduction of advanced diagnostic tools such as Expert Ultra and Quantifront TB Go Plus, replacing the old ones, the healthcare infrastructure has witnessed a remarkable enhancement in TB case identification and management. These advancements basically underscore Malaysia's commitment to bolster disease surveillance and patient care.
The fifth strand of NSP for tuberculosis control 2016 to 2020 successfully strengthened programmatic management of LTBI will now be discussed. The poor result of TB therapy is the policy problem number 7, which has to be addressed by goal number 6. IGRA and LTBI diagnostic method may be able to predict the emergence of active tuberculosis earlier than TST. Matas 2019 reported that interferon gamma release tests had greater predictive capacity in detecting the start of active TB in immunocompromised persons and children. The BCG immunizations program successful enhancement is the next strength. The government resolved policy difficulty number 6 and accomplished goal number 7. According to our data, more than 90% of Malaysian youngsters are presently vaccinated against the BCG. The WHO statistics, which shows that Malaysia's BCG vaccination coverage among 1 year old in 2021 reached an incredible 99%, adds a credence to these impressive achievements. The Malaysian Ministry of Health has also worked hard to increase public understanding of the importance of the BCG vaccine. The uninterrupted supply of TB medications with guaranteed quality is the seventh strand. Through the application of multiple NSP techniques, Objective 8 has been accomplished. Since using the DOTS strategy to combat tuberculosis in 2002, Malaysia has developed and implemented high-quality tuberculosis management. By ensuring a consistent supply of high-quality, guaranteed anti-TB drugs, GDF has helped 78 countries enhance TB control through the implementations of DOTS, the cornerstones of the Stop TB strategy. That means that the DOTS program will provide Malaysia significant opportunities to assure a continuous supply of high-quality, guaranteed TB drugs even if Ministry of Health Malaysia's 2016 recommendations haven't been revised yet. The 9th objective has been fulfilled, effectively controlling tuberculosis as a result of policy problem 8 and a successful supportive environment and also systems. A more systematic approach to TB screening has been advocated by the WHO. The sensitivity of symptom screening has been shown to be roughly 69%. However, the addition of CXR would result in a sensitivity increase of up to 11% and an approximately 2.5-fold increase in the detections of TB patients. Malaysia has achieved impressively strides in lowering the number of cases of TB. The other indicator is that there are no catastrophic costs for any tuberculosis affected households. Goal number 10 was effectively accomplished by guaranteeing that no household in Malaysia incurs catastrophic costs as a result of tuberculosis, inspiring sources for developing a national strategy plan for tuberculosis prevention, treatment, and control include the anti-TB strategy, the regional framework, and the global report on 2016. A partial 25% decrease in TB-related mortality as compared to 2015, a 100% increase in tuberculosis incidence rate to 100 per 100,000 people from 79 per 100,000 people in 2015 due to improve of the detections. The evolution of the trend strength is effectively boost Malaysia's adherence to TB treatment. It may be concluded that AIM number 11 has been successful in producing mobile applications for gamified real-time video observable treatment with short-form GRVOTS, which helps to ease the burden on policy problem number 10, which a much higher score of 90.87% compared to the typical 80%. The result demonstrates that the GRVOTS mobile apps is beneficial in increasing patient excitement at 3 distinct time intervals and boosting treatment adherence. To put it briefly, GRVOTS, a theory-based smartphone application that combines gamifications in real time, seems to be a promising development for raising medication adherence and motivation among TB patients.
Firstly, let's examine the issue of low case detection among immigrants, which is a problem that still persists. Despite the policy's objective 1 to enhance case detection, many immigrants remain undetected due to fear of repercussions and challenges in accessing healthcare. This is evidenced by the fact as of 2022, the case detection of TB for immigrants in Malaysia is still low. As reported by Bernama in 2019, undocumented immigrants often avoid a mandatory tuberculosis screening out of fear of imprisonment or deportation. This reluctance to seek medical help basically contributes to the underestimation of tuberculosis true impact within this population. For instance, a study by Sahabat Iti Alia in 2016 revealed that only a fraction of immigrant plantation workers exhibiting a TB symptom sought medical attention, highlighting the significant challenges in screening this demographic. Moreover, a recent report from the STAR in 2024 indicate a resurgence of tuberculosis, further underscoring the persistent issue of low case detection among non-Malaysians. Moving on to the second objective aimed at improving TB control among children, the government encountered another obstacle. Despite effort to enhance pediatric TB management, objective 2 remains unachieved. The persistent policy problem 3 of low case detection among children basically exacerbate the situation. This is compounded by the challenges in the diagnosing pediatric TB as highlighted by Awaluddin Iti Alia in 2020. Basically, limited awareness, delayed diagnosis and also financial barriers hinder the access to timely medical care for the children, especially the non-Malaysian. Alarmingly, research by Goro Iti Alia in 2020 found low case detection rates among children in Sabah, emphasizing the urgent need to improve for the detection strategies. Next, the inadequacy of resources provided by the government exacerbates the situation. The National Health and Mobility Survey of 2020 identified key factors such as proximity to health facilities and staffing shortages as contributors to the rising TB cases. Even after policy implementation, the challenges persist, as seen in Kota Kinabalu, Sabah, where TB controls effort are impeded by the space shortages and also logistical barriers. Delays in TB investigation are compounded by long travel times and limited diagnostic services. So the government actually must address these resources gaps effectively to tackle the TB crisis. And this shows that the objective is not achieved and the policy problem is not addressed fully.
I will go further into the detail about this NSP sport issue. LTBI's programmatic management is still under the progress. Poor TB treatment outcomes for LTBI in Malaysia are the 7 policy concerns, resulting from partial achievement of some of the objectives outlined in Objective 6. One reason for the paucity of IGRA availability in Malaysia is its expensive cost and laboratory requirements. However, a meta-analysis found that IGRA consistently yields good specificity for quantiferin and T-spot. Second, there is still a lack of frequency, breadth, and depth in the present TB training program for healthcare practitioners for handling LTBI and TB in children. The public's and healthcare professionals' ignorance about LTBI is the next matters, which results in a low level of acceptability of LTBI therapy. Finally, Malaysia does not have access to rifampicin, the recommended course of therapy for LTBI. These are the present limiting constraints that make it difficult to implement the CPG guidelines. Not to mention, despite being high priorities in TB control programs, research and innovations have not succeeded in lowering the number of TB-related deaths based on the policy problem number 10, which supports the increased research and innovation on AM11, a statistical study of TB mortality between 2015 and 2020 may be used to make the conclusions. The 2020 TB strategy milestone require Malaysia to reduce TB-related mortality from 2015 to 2020 by 35%. However, they were not met. Instead, the number of TB deaths reported in the 2020 rose by 21% at the state level in Selangor and by 37% at the federal level in comparison to statistics from 2015. 10% of the 19.3% of patients whose novel treatment outcomes fails also died. 5% were lost to follow-up and 3% had results that were not analyzed, leaving the remaining patients to receive inadequate medications according to the research example.
The first recommendation is by enhancing tuberculosis screening among the foreigners. FOMEMA, designated by the Malaysian government, supports the Ministry of Health by overseeing health screening for authorized foreign workers in Peninsular Malaysia and also Labuan. This program aims to protect Malaysians' health by reducing infectious disease risks from foreign workers and also managing chronic illnesses, said by Empowering Health and Safeguarding Nation in 2023. Foreign workers must undergo a mandatory screening set by the government, ensuring control over tuberculosis and overall health management. Meanwhile, the second recommendation is improving tuberculosis control among children in Malaysia is a crucial matter. The Malaysian government needs to actively educate and raise awareness about tuberculosis, particularly among parents, to promote early detection and also prevention, said by Rahmawati et al. In 2022. Efforts to combat childhood TB are ongoing with initiatives such as involving parents in treatment trials as observed in Indonesia. Collaborating with pediatric specialists, the health department can create child-friendly screening environments tailored to children's preferences. Given Malaysia's diverse population, including many foreigners, the government should consider reducing medication costs for non-Malaysians to ensure that equitability access to treatment as highlighted in cases in Sabah. Proceeding to the next point of the recommendation is by increasing the resources provided by the government to effectively combat the disease. The government is advised to prioritize states with the less exposure and attention regarding to medical issues, ensuring adequate facilities in marginalized areas and also deep understanding of diseases like tuberculosis among healthcare workers to effectively manage and treat them, said Ibrahim et al. In 2014. Proper allocation of funds is crucial to avoid missed opportunities in education, career advancement, and also healthcare, while proactive subsidies are needed to address access barriers to vital information as seen in Indonesia. Countries can learn from Norway's healthcare policies, where medical fees for pregnant women and also children under 16 are free, highlighting the importance of providing comprehensive medical support to vulnerable groups, said Racine in 2023. Last but not least, the comprehensive management of LTBI can successfully be accomplished. Various factors, including health issues like HIV and drug use, affect LTBI rating and also recovery. Regulated treatment sessions are crucial to prevent TB spread. LTBIs is challenging to detect physically and requires blood tests. Accurate diagnosis involves ruling out active TB disease and testing positive for tuberculosis, said Kim and Kim in 2017. Immigrant screening is vital due to diverse backgrounds. Proper dosing of TB medication also essential. Korea mandates TB vaccination and supports it financially, said by Cho 2018. While in Malaysia, Malaysia should enhance policies and educate leaders about tuberculosis more. Korea also prioritized TB control with strict measures like quarantine and also frequent screenings. So global effort should and needed to combat rising TB cases, whether it's in the meantime and also in further time. At last, the private-public mix, which is PPM, involves engaging healthcare providers from both public and also private sectors following international standards for tuberculosis care. PPM, advocated by the WHO, should be adapted worldwide, especially in high TB burden countries with many immigrants and also foreign workers. Norway successfully managed TB cases by adhering to WHO guidelines, emphasizing completing treatments to prevent resistance. The WHO recommends directly observed therapy, which is DOT, where health workers oversee daily medication intake to ensure treatment success and also monitor side effects, which is in Norway.